let me start then by saying thank you very much for inviting us, and it's a lovely opportunity to get some feedback from you about our project and the way forward. So I'll give you a brief overview of what's going on, and then we've got a few questions we'd like to ask you as experts to help us with the way that we conceptualize what happens next. So obviously, Alison and I are here today to answer any questions, but I'm delighted to see John Jenkins here. And of course, we're presenting on behalf of the whole team of people who are behind the scenes, as it were, today. So the problem statement that we are trying to address is that there are significant barriers to training educators to do interprofessional education. For one thing, our university departments, regulators, funding and estate are not set up for interprofessional education. There are still traditional attitudes between professions that make IPE hard. It's not just that there's mistrust, that's a very negative way of looking at it. There's also a sense of respect. One educator may be very nervous about explaining to another that we do it differently in our profession. Educators learn to teach in their own profession, and individual professional organisations usually set uni-professional guidelines and standards, not just for the training of their own educators, but for how interprofessional education should work. And we found when we did a study a couple of years ago that often educators don't speak the same educational language. They think they do, but when it comes to having an intensive conversation about interprofessional education, sometimes they find that it's hard to communicate effectively around education. Hello, there we go. So this was our project. We felt that in order to facilitate these educational discussions around how educators begin to develop an interprofessional understanding, we needed to actually start right at the basics of what exactly is it that we all have in common. And we realised very quickly that it's actually quite hard to work this out. So we set up a four-phase study, which was partly funded by Higher Education, Health Education England and Health Education and Improvement Wales. We did an extensive online survey and literature review. We then did some consultation and consensus building methods, a nominal group, a meeting and workshop, and a Delphi study, which I'll report in more detail now. So the initial literature survey, the initial literature review was informed by a survey. So we essentially built an online survey and asked lots of people to tell us what standards documents they already used in their professional practice, and to find out something about whether they felt that they were supported in their educational roles. We got 126 responses, and unsurprisingly, around 40% said they didn't have any educator standards that they worked to. Of the remainder, there were many different standards for education that people were working to, including internal university standards and organisations such as the Nursing and Midwifery Council in the UK, the World Health Organization Nurse Educator core competencies, and so on. And of course, all of these documents are very different in nature and structure from each other. So we located 48 international standards and guidance documents. In actual fact, we found a lot more than those, but many of them were focused on institutional and systems approaches to the delivery of education. So the World Federation for Medical Education documents for basic standards for medical education actually didn't mention the training of educators, so we weren't able to use those. So we were only interested in those that addressed individual educators' work. we used NVivo, and we found 42 codes, which represented roughly 21 values in 21 areas of activity. They were very roughly grouped at this stage to make them easy to handle. And what we found was that the most frequent values were a commitment to teamwork, which was often unspecified, personal development and patient safety. And the activities that people did were the usual ones of applying principles of teaching and learning, establishing learning needs, and making use of learning and teaching methods and resources. These are some graphics from our study. They're tiny, and I apologise for that. This is the nightmare slide, really, because nobody can see how tiny the text is. But I'll do my best to explain. If you look at the square on the left, dentistry and nursing, it's a comparison of guidance that we found from the COPDEND organisation, which is the Dental Deans of the UK, compared with the Nursing and Midwifery Council Core Competencies for Educators. And you can see that running down the middle are a whole load of codes that they all shared. There are many of them that they have in common. So it was interesting to see that the dental standards included some things that were not shared with the nurses, and the nurses and midwives shared things that were not shared with the dentists. So the dentists, for example, included admission and a commitment to diversity. Among the ones that the nurses had that the dentists did not have were things like learner well-being and professional qualification. So educators in nursing must have a professional qualification. In dentistry, that's not so important because the whole dental team does teaching, and some of those don't have dental qualifications. Similarly, we compared the Academy of Medical Sciences statement on education with the Practice Educator Professional Standards for Social Work. And there, the overlap was very interesting. The social workers require a lot more of their educators than the Academy of Medical Sciences do. But interestingly, the Academy of Medical Sciences want leadership as a core competence for educators. And the social workers were interested more in things like professional qualification, cost effectiveness, assessment, a commitment to diversity, and some statement about active learning, which the scientists were not interested in. Similarly, the Academy of Medical Educators and the Health and Care Professions Council, the Academy of Medical Educators was more interested in assessment of learning, which you might expect given that doctors spend such a very long time in training, whereas the Health and Care Professionals Council were more interested in professional qualification and admissions. So the work that educators were doing around ensuring that basic standards of licensure were met. We took all of these codes along to a nominal group, which involved 8 expert educators, and we asked them to consider all of the results that we'd found and to vote and discuss on those things that were most important. Now, they came up with a very interesting set of values. They felt that professionalism and communication were important, and they talked about inspiring and challenging. They wanted to get something of the need for an educator to be a role model. And they tended to compress the activities into very broad brush, so that within efficient and effective learning and teaching were about 12 of the codes that we'd actually come up with, which made it interesting, but clearly in terms of identifying individual areas of activity, it wasn't quite so helpful. They had a very high level view of what education was about, however, which we found very useful. John and I did a workshop subsequently at INHOE, the International Network of Health Workforce Education in Dublin in 2019. And again, we took all of these values and activities along and asked groups to sort them into themes. What we were interested in was whether they thought there were any that could be dismissed, any that they thought we'd left out, and where the themes could perhaps be combined, or where they weren't expressed in a way they understood. And this was interesting because it revealed some conceptual issues. They were interested in the division between what was the responsibility of the individual and what was the responsibility of the institution. Where was collective responsibility in good educational practice for educators? They wondered what the level was expected of all educators, because obviously we were looking for baseline entry level standards, but it was clear that some professions had higher expectations than others of what could reasonably be expected of a relatively new practitioner in education within that profession. And they established that there was confusion about the relationship between values and activities, whether it's something that you did or something that you believed. And these are just some snapshots of the work that they did. You can see that Group 5 here actually decided that 8 of the things that we'd come up with were not needed, but they included other items that we hadn't included, such as consideration of learning needs. This group were obviously trying to divide it into activities and behaviours, but they included mentoring, and they crossed out, they put in and then they crossed out again, educator well-being. So you can see there was some intensive discussion. Again, we used those findings to consolidate what we'd got. And by this stage, we realised that it was closer to 8 values and 22 activities. So we took these various activities to them and asked them which were essential, desirable, optional, or not necessary, and we coded those. So there were 2 rounds of this. We were pleased to see that there was considerable consensus that in the first round, 8 values and 22 activities were straightforward, accepted. And on round 2, only another 1 value and 3 activities were added, which suggests that there was very high consensus. So the total that we had at this stage was 9 values and 25 activities. And this was the final framework. I've put on the right here a link to the full document, which is the executive summary of the project. So you can read it at more leisure, and it will also be in the reference list. But you can see that what we had by this stage was a central set of values, and these were the final 9 values that were arrived at, plus 4 areas of activity: preparation for teaching, teaching and learning. Sorry, you can't see that because of the screen share strip, learner progression, and quality. And we were interested in this because, of course, it leads to a natural plan, do, study, act spiral, which hopefully if you go through all of these various activities, you are leading yourself towards a beneficial spiral of improvement. And just in case you can't see, those were the final values that we'll come up with. And again, I think most of us would agree that these are the kind of values that we adhere to as educators, even though they're not often explicitly stated. These were the ones that I think most people felt that they could work to. And again, they were the ones that everybody agreed. So, in conclusion, we used an approach which we think built a consensus from among a very wide range of professionals. There were 18 different professions represented within the Delphi study alone. So we felt that this was a fair recognition that consensus had been achieved. It enabled us to discuss some quite fundamental issues around values and activities within education. In other words, when you're setting a framework for educator recognition, are you looking at basic activities, or are you going to try to pitch it so that it's more aspirational, that will encourage people to improve? how do you draw the line between what people should know and what they should do? We argued very much that it was about what people do, that was what needed to be evidenced, so that it was very much the top level of Miller's pyramid that we were looking at for must be able to practice effectively. The question about values and activities came up a number of times. People couldn't work out whether things like teamwork was an activity that people just did, or whether in fact it was also, there was something more to that one had to be actually committed to teamwork in order to do it. Leadership was a constant theme, and as we expected from the nominal group, who rated leadership quite highly, whereas other groups rated it less highly. There was again this view, who is actually ultimately responsible for the education that takes place at the bedside, in the clinic or in the classroom? Is it a collective responsibility or is it an individual responsibility? And we suggested that actually there is a concept of collective responsibility. In other words, you might not individually be responsible for setting the assessment, but you do have a responsibility to ensure that when you are explaining it to students, you understand what it is that you're expecting them to do. And then, of course, there was the locus of responsibility for good education between the employer and the individual. And again, this was very much about what is your responsibility as an individual for ensuring patient safety, compared with the responsibility of the educator, of the employer. What are we doing next? Well, we're already working on a project with Health Education England in London to pilot test this framework, to see now whether in fact we've come up with this framework, whether it can now be retrofitted, as it were, to see what practitioners feel about it and whether it's usable. We particularly are interested in identifying further developments in terms of what are profession-specific that are not covered by our framework. Because clearly, if you are a paramedic educator, you're going to need a set of additional skills that may not be covered by these basic, by this basic framework. And we're interested in the fact that at the moment, the framework that we have, we think provides a common shared foundation of a basic minimum of what every healthcare educator can agree is necessary to explore those subsequent stages in a healthcare educator's professional development. How far can we go with this? And in particular, how can we recognise and reward those who are putting additional efforts into developing themselves as leaders, managers, scholars, researchers, and expert teachers. So this is what we're doing next. In July, we are running an online workshop. It was going to be face-to-face, but it's now going to be online, which is giving us a whole new collection of headaches with a cross-professional group of volunteers from London. And we're going to get them to consider this framework, to think about the feasibility of using it across those professional groups, and to give us some feedback on whether, in fact, they think it does reflect what they do. We also want to have some explorative discussions about the further stages of professional development, and to help them perhaps use this framework as a way of marshalling their information, their performance information, their reflections, their activities, so that when they're to help them have more meaningful discussions with their managers about their work as educators, using these values and domains of activities. Finally, we're going to be looking at profession-specific additions to these basic minimum, and we're also currently undertaking a literature review to uncover what interprofessional education specific competences there might be needed. Obviously, we know that there are a huge number of IPE specific guidelines already, and we would like to have a look at all of those and see what they all have in common. And then the next bit will be to identify what's expected of interprofessional healthcare educators based on what we know already. So these are the questions that we think are going to inform the next stages of our work, and these are the ones that we would really like your help with. The first question is that we think that an awful lot of the literature assumes that if you're a good healthcare educator, you'll automatically be a good interprofessional healthcare educator. But what we know about team competence suggests that that may not be the case, that somebody who works well in a monoprofessional team to teach may not work so effectively in a multi-professional team. We'd like to know what additional skills an interprofessional healthcare educator needs. Are they just an expansion of the framework that we've already come up with, or are there actually more skills that need to be added to the mix? And finally, how would we be able to identify a competent interprofessional education team at a higher level? So that's our contact details, and presumably once the slides and so forth are made available, we'd be very happy to talk it over with you and to answer any further questions you've got. And these are our references. So thank you very much. I hope I haven't gone on for too long.